All right, we are going to go ahead and get started. So this talk is on medical ethics as it pertains to the boards, and much like yesterday with geriatrics, I hope this will also be useful in your day-to-day clinical practice. And I want to acknowledge Dr. Joy Swift, who assembled these slides, and is of course one of the really stalwart members of the Washington ACP chapter, has been our governor, and has done a lot for the chapter and for the clinician community in Washington, as well as medical education. So, in terms of ethics of medical care, I like one of the ways that Dr. Wood phrased this, that all cases have ethics, and most of the time they just go smoothly. So it's not a point that right, warrants any particular call out. It's the times when it doesn't that, in particular, it really gets thorny. And we're going to talk about some of those situations where you might be tested on the boards, and of course, it might come up in clinical practice. We're going to kind of review this in terms of four lenses or four aspects when it comes to medical ethics cases. The first is we're thinking about the medical indications, and then very important patient preferences. Then we're going to integrate quality of life, and then think about other particular contextual features, things like social and economic factors, legal issues, particularly as it pertains to the state you're practicing in, because states have different laws, and then other administrative considerations. We may not get to all of the questions, and like all of the talks that you will have from us, there is an answer key at the end so that when you go back through it at your leisure, you'll be able to look up answers. I shared yesterday the blueprint for the internal medicine boards, and in terms of ethics, this could be up to 3% of the exam. Uh, It's kind of broken down into two different areas. It's referenced under the geriatric section in terms of ethics for elderly patients and also in the context of end of life considerations and palliative care, but also independent of that, ethical considerations that might come up in whether inpatient or outpatient care. As far as how you approach a question, and I would encourage you to think about this with all questions, not just medical ethics questions, but you want to think about what is the objective of the case. And with ethics questions, really, what is the ethical principle that they are testing you on and that is guiding your decision making? Now, as a brief aside, we also have a talk on test taking strategy, which is not one that we have within the live lectures that we give, but you'll have access to the slides for that. And at any point, if anyone has questions about tailoring their own test taking strategy, please feel free to reach out to me and I'd be happy to speak with you about that. So, our first case. Um, so we have a 62-year-old gentleman, and this is a patient of mine actually, with long-standing chronic kidney disease, and is admitted for volume overload and some hyperkalemia due to, of course, progression of the chronic kidney disease now at end stage. The patient has been working with their outpatient nephrologist for years, and it's no surprise that end-stage renal disease was on the way. And they discussed dialysis and, in fact, preparing for it prior to this. And the patient had chosen not to pursue dialysis when their time came, when the CKD progressed, and instead they would proceed with hospice. The hospitalist team taking care of them brought up dialysis, though, of course, for the acute issue with hyperkalemia and the fact that they had anasarca, and the patient declined. So, case one, we have the 62-year-old gentleman, end-stage renal disease, now needing dialysis. He is declining. What should you do? So, answer choice A, have the patient declared incompetent due to likely encephalopathy. After all, they are stage 5 chronic kidney disease and uremic. I didn't give you the labs, but they are uremic. B, refer the patient back to nephrology for another discussion. After all, this is end of life. And are they sure they really don't want to pursue dialysis? C, offer palliative care. And D, strongly urge the patient to have a tunneled catheter to proceed with hemodialysis acutely and then defer the long-term decision to outpatient follow-up. I appreciate. So Hala, not able to use the poll to answer, and I see no answers coming in. Sharon, could we try relaunching the poll?
Do you see the poll now?
I
No?
did see the poll, and now I see it
Then
again. Are others able to? I don't see any answers coming in.
I don't see any answers coming in.
Hmm. We just see the poll results. That
How
is a
about
strange
now?
bug.
Hmm. The poll's working, right? You do see the poll?
We see the poll screen, but I also am not able to answer into the poll.
Um, Let me relaunch it. One moment.
Thanks, Sharon. We have quite a few questions, so we will see if we can sort this out. I appreciate everyone who is entering into the Q&A.
Hmm. Let me try one more time.
And if this doesn't work, we'll proceed. Um,
Okay. That's odd. Do you see the poll?
Not yet. Okay, I can see the poll and it looks like no answers, so I'm guessing our attendees are not able to enter answers. Um, I know the Q&A is not the ideal way to put answers in, but if you could put what answer choice you would choose, I'd appreciate that, just to get a sense, and so I can tailor my explanations. So I appreciate LL, and I'm getting a lot of C's. And I appreciate that comment, Elena. We may want to look at switching then. Okay, so C's, offering palliative care. And I agree with everyone who's putting that in. I think here that is by far and away the strongest answer. And so when we think about what is the ethical principle that guides our decision in this case, one of the really points of emphasis, of course, in our country and our medical system is respect for patient autonomy. It's really a very treasured pillar when we think about patient care. Um, and it's a point of strong emphasis. I think likely all of you have had numerous talks during medical school. And of course, in the course of your residency, it's been a point that has come up, I'm sure, on complicated inpatient cases. The focus is on patient choice, and really rather than the choice of others, whether that's family, um, friends, others, right, society in general. It's about patient choice. This has been upheld in the courts a number of times. Now, I will say as a caveat, and we'll come to a case later, children are more complicated. In certain situations with teens, they may be able to voice a preference that's different than what their patients might say, but generally, children are different. And of course, we are internists. You're probably all thinking you are not pediatricians. There is the potential that because you may care for teenagers, that some cases may come up. So it will be helpful for us to discuss this, and we will in a little bit. But generally, of course, we're focused on adults, and then really a point of respecting patient autonomy is very important. Nonetheless, one of the best things we can do is have really strong and clear communication. Again, our role is to be advocates for our patients, but nonetheless, at the end of the day, being able to communicate that and help your patient communicate that with their family is very, very important. Again, I am sure I won't ask for a show of hands, but I am sure all of us have cared for patients in situations where families disagreed with what a patient was choosing, and that led to a lot of angst. So I think here, answer choice C, as you're all picking, this really is the one about listening to patient autonomy. I will say, unfortunately, in this actual case, somehow answer choice D is what happened. And it it was a messy clinical situation. And ultimately, a month and a half later, hospice was started and the tunneled catheter was removed. And there was a lot of suffering on that along that line, along that route. But um, anyways, I appreciate everyone here recognizing that indeed following through with palliative care, um, most appropriate choice. So case number two, and again, I'm going to ask if we can use the Q&A feature to put in the answer that you would pick. So now we have a 21-year-old college student, and they're brought in by their roommate for acute symptoms of a headache and stiff neck for the last day or so. No significant past medical history. The patient is somnolent but arousable. They are febrile. They are tachycardic. They have nuchal rigidity. So you know where this is going. Labs are notable for a white cell count of 24. In the ED, you're able to obtain consent, of course, for the lumbar puncture for diagnosis, and of course, starting that stat, likely ceftriaxone and potentially vancomycin. The patient hears the order and becomes agitated, refusing antibiotics. The physician carefully explains the high risk of death from meningitis and disability. The patient continues to refuse, but is becoming increasingly somnolent and is quite altered. So in this case, what is the most appropriate care? Is it treat with IV fluids only? As antibiotic therapy does carry a significant risk and we should respect the patient's wishes. Is it since the patient has a life-threatening condition, he should be treated against his will? Is it obtain a court order urgently, withholding treatment until the case can be reviewed? Or is it obtain consent from the patient's roommate and then proceed with antibiotic therapy?
Is the poll working? It looks like it's working right now.
Ooh, I can see the poll. Wonderful. Okay, great. Thank you, everyone. All right. So it looks like we are favoring, since the patient has a life-threatening condition, they should be treated against their will, and then potentially thinking about obtaining a court order urgently. So for this case, what is the ethical principle that's going to guide our decision? So here, I mean, we're still thinking about patient autonomy, but we're also thinking about beneficence and thinking about the importance of treating our patient, particularly when they may not be in their normal state of mind. And again, our obligation is not only to do no harm, but also to help our patients and relieve suffering. And so we have an obligation to assist others, our patients, and again to help them, and at the same time, as much as we can, to do no harm. And this is a challenging situation because, on one hand, the patient has the right to refuse treatment for a life-threatening condition. Um, Again, here, meningitis. However, the risk of treatment, even though there is some risk with antibiotics, the risk is rather low compared to the risk of disability and death with meningitis. And again, they're not able to voice why they have their objection, and they have a medical condition that we do know causes right alteration in mental status, which impacts their ability to have capacity and to make informed decisions. So in this situation, I think it'd be very safe to say it's unclear if the patient is making that decision with a full understanding of the risks. And so it is appropriate and ethical to treat against their will, and also you are on firm legal ground. So here, the best answer choice would be to proceed with treatment, even though it is against their stated will in that moment. Uh, as far as obtaining a court order, and having been through this a couple of times now in my career, I can say this is a very slow process. The courts take a long time. Um, Whatever's going to happen with this meningitis will have happened long before we get an answer from any courts. And generally speaking, for the test for any urgent or emergent situation, going to the courts is never going to be the right answer. And it also isn't a right answer in your clinical practice, generally speaking, because when things are urgent and emergent, courts are not going to happen quickly. Now, there are some other contextual features that it's helpful to know, other preferences that do impact and matter, and that may be harder potentially to explain, but have been upheld. So when we think about religious preferences, adults can refuse care based on stated religious preferences. So even if they can't explain the reasoning beyond, this is what my belief system values, that is, again, courts have upheld that that is an appropriate and reasonable reason for a patient to refuse care, and it's one that we should respect. Now, and again, as we talked about, we are internists, we are not pediatricians. However, occasionally we will be taking care of minors, and adults cannot legally withhold life-saving care for their children on a religious basis. That is a small minutia, which again probably won't impact your day-to-day care, but is helpful to know. And another kind of very niche, which as we are not OBs, but women cannot be forced to have cesarean sections or internal fetal monitoring, again, if it is opposed to their religious beliefs. Other kind of contextual features would be other cultural differences, and practicing in the greater Seattle area, you've likely taken care of a wide range of people from different backgrounds. And in some cultures, it is more acceptable to have grown children or others in the family take responsibility for a patient. And so a patient may defer to others, to their children or to a matriarch or a patriarch to make decisions for them, um, or even to have them be informed of a serious condition and not inform the patient themselves in order to protect them. And this can be problematic. I've had a couple cases early in my career where it caused a significant amount of moral distress and injury to the team because we did not feel comfortable, although the patient and their family very clearly expressed that there was a different decision maker and everything was to be routed through that person. So the best way to approach this, and I don't have a firm, this is the right way to do it every time, but it's to have a very open and respectful conversation and to really clarify. I have used a lot of phrasing along the lines of, well, if we were to have something that was life-threatening or a very serious condition, would you still want all of this information to go through family member X instead? And who would you like to make medical decisions, even if it was something very serious or life-threatening? And that helps reassure, depending on what they say, that yes, indeed, this is what they want, and they are making an informed decision, which is in keeping with their own deeply held beliefs. We're going to transition now to talk about disclosing information. So our next case, and notice this says case forward, is because I've skipped one of the cases. You will see it if you review the slides, and the answer to that question is also at the end of the talk. But for case 4, we have a 56-year-old man with type 2 diabetes, and he's being hospitalized for treatment of cellulitis, given 100 units of long-acting insulin when normally his dose is 10 units. The mistake is fortunately discovered shortly after, and the patient is placed on a dextrose IV drip to help mitigate the risk of hypoglycemia. So for our next case, and Sharon, if we could launch the poll, should we say nothing, disclose the error only if the patient asks about it? Should we say, you are at risk for low blood sugar, so you will be receiving a drip with glucose in it? Should we say, we are concerned that you could have too much insulin and may develop low blood sugar, so we'll be monitoring you closely with the glucose drip? Or should you say, a dosage error was made, you received 10 times the insulin dose that was ordered, you were saving glucose to prevent low blood sugar? Great. So overwhelmingly, we have answer choice D, and I love this, and I am glad that we are all on the same page. So we're thinking about the very active acknowledgement that an error was made and also explanation of what is being done to correct it. So I won't spend a lot of time going over this, but a medical error should be disclosed. Patients overwhelmingly express that they want to know. And an important point is disclosure is not conditioned on the likelihood of whether or not there will be anything that comes of the error or if it would otherwise be recognized. And a key thing, like errors happen. We are all human. We are part of a very complex medical system. And an error happening does not mean that something negligent or unethical happened to cause said error. But failure to discuss it or avoiding talking about it can do so. That can really compromise the patient-clinician relationship and trust. So it sounds like, as we all know, we are ethically obligated to be forthcoming about errors. And again, almost without exception, patients want to know, even when they're minor errors, that where nothing is likely to come of it at all. Uh, The unfortunate and frustrating side of it is that, generally speaking, we physicians do not do a great job of disclosing those errors, even though, again, we are obligated to do so and patients expect us to do so. And not that this should inform your decision about sharing, but also generally patients who are informed of the mistakes and what is being done to correct them are less likely to pursue legal action. In fact, the two reasons most often cited by patients when it comes to litigation against clinicians and physicians is that they don't feel like the medical team is being honest about mistakes that happened, and they haven't had an apology. Like, those are the two most frequently cited reasons. Now, should a mistake happen, and again, it is very likely to happen during your career. Again, we are all humans and we take care of many, many people. It's a lot of opportunities for mistakes to happen. It's important to also explain what is being done to treat or address what has happened. And then, depending where you are, it can be helpful to notify your risk management team. And not because you are worried about litigation, but because they can be helpful in problem solving. They can be helpful in having the communication that needs to happen with patients, for getting a sit down, for helping with wording and explanations in a way that is both patient-centered and friendly. And so they can help do a lot of other things. And I will say, having worked with risk management at different institutions, they can be very helpful. Other things they can do, of course, potentially would be to help remove the financial component to billing. And a key point, you do not have to offer financial restitution to patients for mistakes. So I think here, as we all picked, the active explanation that something was done and we're also doing something to treat it and to protect you, the patient, from harm. Okay, case five, which we're going to look at, the situation of a minor patient. We have a 16-year-old athlete who comes to urgent care for a physical exam because, of course, they're required to have a sports physical. The patient's mother, who is their legal guardian, is at work and not able to come. And the patient has no contact with their father. The chart reveals numerous missed appointments, unfortunately. And it has been more than 10 years since their last tetanus shot. The patient is anxious to have the tetanus booster so that they can play. And she shows adequate understanding of the potential complications of vaccinations. She also asks about contraception while she is seeing you. And on exam, it's reassuring. So, case number five and question five, and Sharon, if we could pull up the poll. The state that you're practicing in has a mature minor statute and laws about care for emancipated minors that do not include immunizations in urgent care. What should be given in the care of this patient? So, should we give information about contraception and give the tetanus booster? Should we defer both the tetanus and contraception discussion until the mother is available? Should we defer the vaccination but do provide information about contraception? Or should we give the tetanus booster and defer the contraception discussion until the mother is available? There are a lot of A and B choices here to sort out. All right. So great. We have a nice split between A and C. So we're kind of torn between give information about contraception and the tetanus booster versus defer the booster, but do provide information about contraception. And I do want to call out that it is important to know the laws of the state you are practicing in. Not all states are the same. I've spent my entire career practicing in Washington, and depending on where your career takes you, you may practice in other states or, of course, other countries where laws can be different. So when we think about the care of minors, one aspect is minors can change their status legally to act on their behalf, to become emancipated. That is very rarely done. I personally have never seen that in my own career. Some of you may have. And generally, there's a lot of extenuating circumstances. And that, of course, there's a legal process involved. Now, aside from an emancipated minor, which is very different, so a minor who has not perceived that legal process to be emancipated, there are laws around exceptions to the requirement to having a guardian's consent for care. So exceptions where we do not have to obtain consent are anything emergent or urgent. So obviously, should a 16-year-old come in because of a car collision and they're severely injured, you don't have to wait until getting consent from their guardian to proceed with life-saving treatment, right? You just proceed with it. For sexually transmitted infections, for pregnancy and contraception, Keely, these are also included in the state of Washington, specifically for contraception. There's a call out, do not have to have guardian consent. Now, that said, the age of consent for a minor to proceed with any of these, for things like contraception, there may be age requirements that can vary state by state. It's a little confusing. But in certain states, at 12, they may not be able to, but at 14, they could be able to. So again, this is where it helps to know your state's laws. Now, often when we look across the United States, immunizations are not included on this exception to consent because generally, of course, immunizations are not urgent emergent. They're not life-saving treatment in the moment. So as this question stem calls out, vaccines are not included as something that does not require a guardian consent. So for this case, very likely you would not proceed with the booster. And I'll come back and I'll show you the question in a moment. Now, the mature minor treatment statute, which is referenced in the question stem, So minors can receive immunizations or other treatment without parental consent under the mature minor doctrine, and this requires the clinician to be able to evaluate and attest that they think that the minor has the intelligence, the maturity, the training, the understanding, um, and the independence that allows them to make an appropriate decision that they understand, and they're in a situation where they would be able to do that free from the consent and control of their guardian. Do you notice I said a lot of requirements there? The way to interpret that, I think, is that in the state of Washington, if you did a very thorough discussion with this patient and you felt confident again that they had the maturity, the experience, the understanding, and they were in a social situation where they weren't able to easily have their guardian there, then you could proceed with the vaccination. Um, you could proceed with the vaccination at that visit. In this question stem, I don't think we have sufficient information to say that. And I also, this is included more to be helpful for your practice in medicine. Unlikely that this would come up on the boards. So this is very much a minutia, but it is helpful for us all to know. Um, I also want to call out the University of Washington has a really nice handout for Washington State. I've included just a snapshot of it here, breaking down when a minor's consent is sufficient without the minor mature statute. Um, versus when a parent or guardian's consent is required. And so, just in Washington, as I mentioned, generally, uh, minor's consent is not sufficient. We need the guardian. For STIs, we can proceed with treatment if they're over the age of 14. Birth control services and contraception, an emergency contraception can be provided with the minor's consent without guardian consent. Um, and I've also included a slide on the mature minor, the factors that you would have to attest to as the clinician if you're going to say that the patient you are seeing that day meets the mature minor criteria for that statute in Washington. This is just included for your reference. Do not spend time memorizing this. If you're ever in this situation, documentation is your friend, and you want to be very clear about why you are proceeding with that treatment without the guardian if it is something like an immunization. All right. So getting back to case five here, I think the firmest ground would be to defer the booster, but you would appropriately provide information about contraception. So answer choice C. Okay. We're going to transition to looking at another aspect, another pillar to consider when looking at ethics and ethical dilemmas. So, case six, we now have a 49-year-old who had two tooth extractions for caries, and he was given oxycodone for 5 days post-procedure. He, of course, calls you on Friday afternoon. This always happens on Friday afternoon for an additional 5-day course, right? It's the weekend because he's having ongoing pain. Again, those were painful extractions. He's not having any sight bleeding, swelling, or drainage, no fever or neck pain, right? No red flag symptoms. Past medical history is notable for a history of thromboembolisms, and he's on apixaban for anticoagulation. And of course, the dental office is closed because it's Friday afternoon and you were on call and working late, etc. So for case six, and Sharon, if we could put up the questions, what is the most appropriate acute analgesic plan? Is it start them on duloxetine? Is it recommend ibuprofen? Is it prescribing tramadol? Is it bringing them in urgently for an injection of ketorolac? Or is it recommending acetaminophen? Okay, great. We are between prescribing tramadol and acetaminophen. And so I think this is hopefully then a really helpful case for you for us to discuss. Um, Why not just give a few more days? And of course, tramadol is a less potent opiate than oxycodone. So, right, presumably less harm, right? That would be a reasoning behind answer choice C. Well, and this is hopefully everyone has seen this, but if not, this might be shocking data to you. Patients who are opiate naive who are given a 10-day course of oxycodone for a dental procedure. just for a dental procedure. 1 year later, 1 in 5 of those patients are still on oxycodone. And 3 years later, 1 in 6 of those patients are still on oxycodone. So, not taking opiates, just given a short course for a type of post-operative pain, a significant number then become chronically on opiates. This is one of the many reasons why, over the last 10 to 15 years, there has been increasing attention to how do we reduce opiate prescribing and really limit it to situations where we are confident we are doing more benefit than harm. So, when we think about pain management, and in fact, uh, this type of question is very much fair game for the boards, and I will just say anecdotally, I have seen this question for the boards, this type of question focusing on this very point. Um, when you're approaching on the boards and indeed in your practice, you want to be highly judicious in the use of opioids. They are unfortunately highly habit forming and addictive. I hate to use that word addictive with patients because it has all sorts of connotations, but highly addictive medications. Um, Situations where you are in firm ground, definitely advanced malignancies and hospice, right? We have data that says that the risk of dependency is low, you are doing good, and that you might be even extending the quality of life and duration of their life in those settings. Again, benefits outweigh the risks and the harms. You want to be really careful when you're using it in non-cancer acute care and very careful in chronic pain. Now, there are a lot of patients, again, legacy might be a term we use for this, who have been on long-standing opiates. And this is a very challenging area. Depending on the practice you go into, you might find yourself with a lot of these patients on your panel. I certainly did when I started practice. And it's challenging, and we have to be very cautious. Generally speaking, good rules of thumb, minimal days, particularly like after procedures, the shortest course possible. Orthopedic teams have done a really good job at saying, how can we limit the number of opiates? We want to get our patients off opiates and moving as quickly as possible. If you have to use, you have to assess their risks. For documentation purposes, you really have to be clear that you are documenting that you've assessed them for risk of misuse and that you are checking things like if your state has a prescriber database, the way Washington State does, that you are checking it. And when you're prescribing, you want the shortest duration possible and avoid, of course, renewing when it's for acute uses. And wherever possible, prescribe non-opiate pain options and multimodal therapy. You also really want to avoid high-risk combinations, particularly opiates and benzos, which carry a 10 to 20-fold increased risk of death, like just staggeringly scary. And for those who aren't comfortable with buprenorphine prescribing, I'd really encourage you. There are lots of CME courses which focus on bup. It is very straightforward. It has become a larger part of my practice, a much safer opiate, and it can have wonderful effects in helping people regain their lives when they are opiate dependent. So buprenorphine, again, just a short plug for learning how to prescribe it and use it. So for this case, I think here the best answer choice is acetaminophen. Um, because uh, the risks for recommending acetaminophen very, very low, particularly for an acute course. And unlike tramadol, which again would be an opiate, we are avoiding opiates for post-op acute pain. Now, there's a question from AP. Can you expand a little on the urine drug screen use? That's a great question. So I think AP, it's unlikely that you would have a question phrased in such a way where one of the answer choices is obtain a UDS, although potentially in an ER setting that might be the case with altered mental status. I think that's the more likely context to see it. Um, More likely it would be in the setting of an outpatient case where you are given the results of a UDS, and then that should inform how you think about answer choices. It may be something like the patient's urine drug screen also shows evidence of substance X or Y, how best to approach the situation. So hopefully that helps, AP. All right. We're going to go on to case 7. And if we could prepare the poll, Sharon. So Miss C is an 84-year-old woman who resides in a skilled nursing facility. And she's admitted with an aspiration pneumonia. She is unconscious and declining. Blood gas is a pH of 7.28, BCO2 of 60, O2 of 52. The patient is started on IV antibiotics and fluids. Her niece, who is the durable power of attorney for healthcare, and you have that on file. The patient, unfortunately, has never completed a living will or an advance directive or a portable orders of life-sustaining treatment, that bright neon green form. The niece comes in to meet with you. They state that their aunt has progressive dementia over many years. The niece would like the IV fluids and antibiotics discontinued with a focus on comfort care only. The patient does have a daughter who is out of state and not available to join for a care conference. So, case 7. Which of the following statements regarding the niece would be the most correct? Is it the niece's request to discontinue the fluids and antibiotics is within her capacity to act as the patient's durable power of attorney? Is it since the patient herself left no advance directive, instructions to DC IV fluids and antibiotics cannot be carried out? Would it be the daughter of the patient would make decisions as next of kin rather than the niece, despite being uh, despite not being named as the durable power of attorney, or rather the niece has been named as such? Or D, the niece's instructions can be carried out only if it is determined that she has discussed this issue with her aunt, which is to say, carrying out substituted judgment. She knows her aunt's wishes and can do attest to that. Wonderful. So we are between A and D. So, durable powers of attorney for healthcare. So this is another situation which can vary state by state, but in the state of Washington, authorize individuals to appoint another person to act as their agent to make all healthcare decisions when they are incapacitated. And so the obligations of being a power of attorney for healthcare are to carry out the patient's wishes, i.e., to use substituted judgment for them, and or if the patient's wishes are unknown or clear, to act in their best interest and welfare as best as you, the power of attorney, can do. You powers of attorney, this includes they are vested with the authority to make any decisions for healthcare, including and not limited to end of life decisions, which include continuing or withholding treatments. One of the challenging situations, and if you haven't been through this in your career, very likely at some point you will, is that the power of attorney supersedes the wishes of family members, and other family members may not be happy about this or may not agree with it. But that also doesn't change the fact that the power of attorney has the ability to carry out the decision making. And an interesting nuance, the power of attorney actually ends with the patient's passing away. And so, just as a sub point, autopsy decisions in the state of Washington fall to next of kin, and there's an order of that. So that's a very nuanced point that probably won't come up often in your career. But anyways, for a patient who is living, the power of attorney, whoever they vested that in, has the ability to make all these decisions. Um, Now, there are limits to it. Um, when a patient is choosing a power of attorney, the patient has to be able to demonstrate that they understand what they are doing and that they are choosing to vest this other person with this authority in the case that they become incapacitated. So, someone who is altered and in the moment where they're trying to assign power of attorney likely cannot, it is not appropriate for them to do so. You also have to be comfortable that the power of attorney is acting in the patient's best interests. And generally speaking, this is not ever going to be an issue, but um, potentially, and I won't go off a lot on this, but potentially you might hear things you're saying, well, I wonder if the power of attorney really does understand the situation in terms of what's going on with the patient. Now, one of the things that all of us can do, which can be very, very helpful to powers of attorney and family members, is to make sure we address these issues before the life-threatening situations happen, i.e., things like the portable orders for life-sustaining treatment. I'm not able to see everyone. If this is a live classroom, I'd ask you all to show your hands if you've had a chance to discuss portable orders for life-sustaining treatment with patients, those neon green forms in Washington. And most states have a version of this. What I tell patients is that they are doing a tremendous service for their family or for their power of attorneys when they answer it in advance, when they feel well, when their health hasn't deteriorated, before they have dementia, because then it takes the burden off of the family member or the power of attorney or the surrogate decision maker. Those people don't have to sit and wonder and debate what would my loved one want or not want. because the loved one has already made that explicitly clear. It is one of the best things that someone can do for their surrogate decision makers in advance. And for all of us in our personal life, we've taken care of very sick patients. I would encourage you, if you have others in your life who would be making those decisions for you, if something happened to you, it's helpful to have the conversations up front. Okay, I will get off my soapbox. Now, when we're talking about power of attorney, another adjacent form that often isn't helpful is a living will. There are lots of different living will forms. Again, I'd ask for a show of hands of who has seen at least three different forms of living will. Um, these are documents that generally allow patients to express their wishes should they become incapacitated in the future. And usually it has a question or a paragraph about what to do if they're in a terminal or irreversible state. Um, as we all know, it's hard to say when someone is in an irreversible coma. And what even is a coma? Is someone who is sedated on the ventilator in a coma, right? The lay press may describe it as that, but we may not necessarily think of it like that. So living wills, they can be helpful for giving guidance in the moment to a surrogate decision maker if we have access to a living will. But generally speaking, those portable orders for life-sustaining treatment are just a lot more useful. Now, getting back to decision making. If someone hasn't designated a power of attorney, um, many states have a listed order, and it is helpful wherever state you're practicing in to know that order. In the state of Washington, that's very clearly laid out. It starts with a court-appointed guardian, followed by power of attorney, followed by, if neither of those things exist, a patient's legal spouse, followed by their adult children, followed by siblings, and then parents. So, like, there is an order, and it can be different depending on the state that you're in. One nice caveat that can be very helpful to you when you're working with a large family of a patient, if multiple family members are requesting that they all want to talk to you, you can delegate and say, well, I'm sorry, I need this to all come through one person. I can inform them, and then they can distribute that to the rest of you. Now, hopefully this doesn't happen often in your career, but occasionally someone does not have a designated person in their life and they're in a situation where they are unable to make decisions for themselves and then maybe in a situation where they do need a guardian. In my geriatrics practice, this comes up disturbingly often. And so we do a lot of work with our social worker to help family navigate how they can get a guardian appointed. But anyways, hopefully in your practices, that is an uncommon thing. And the thing you can do with your own friends and family, and of course with your patients when they are in your clinic and they are well, is to say, have you thought about this? You should do a portable orders for life-sustaining treatment. You should designate someone to make healthcare decisions for you should something come up where you're incapacitated. Now, when thinking about appropriate ethical care and in the setting of course, the boards as well, a short trial of therapy to determine response, particularly when someone has expressed they wouldn't want to be kept alive if their condition was irreversible, it can be beneficial to go with a short course of therapy to see what happens. As we know, in the case of pneumonias, we don't often know what the direction may be. If we think there is something that's causing respiratory failure, but likely is reversible, a short course of intubation may be very reasonable. Um, so also, if someone has a stroke, but we're thinking, again, based on our talk with Dr. Kraus yesterday, well, maybe with thrombolysis, maybe we'll be able to get some good function back and quality of life. It may be reasonable to look at some treatment. Now, an interesting side note, legally speaking, withdrawing care is the same as not initiating care in the first place. And I will say to family, that doesn't always feel intuitive. And in fact, even to clinicians, that doesn't necessarily feel intuitive. It often feels different to take care that's already been provided away as opposed to not starting in the first place. In my practice, this often comes up in the setting of dialysis. It's very different once you're on dialysis to feel like I'm stopping it as opposed to never starting it in the first place. But legally speaking, there is no difference. So for case 7, as most of you chose, the most appropriate thing here is to follow the NICE, the power of attorney's stated very clear request that given the patient's dementia, this is not in keeping with their wishes to proceed with IV fluids and antibiotics and to focus on comfort care. For those who are thinking answer choice D, it may be helpful to ask the NICE if they're struggling with their decision. What do they know about the patient? What had the patient said before they had dementia to help them navigate to making that decision? but their decision is not dependent on the niece being able to say, well, I know my aunt had already laid out what to do in this situation. Okay, we're going to transition to privacy and confidentiality. Um, I appreciate everyone bearing with me. We are approaching the end of the talk. So for case number 8, you are asked to provide records via fax to an outside hospital ER for a 39-year-old patient who came in with fever and dyspnea. They had a mechanical valve replacement for a bicuspid valve a month and a half ago. Which of the following would be in compliance with HIPAA rules? So, Sharon, if we could pull open the poll, would it be the patient's consent is required to verbally fax records? Would it be the patient will need to sign a written release for information to be given? Would it be as a patient is too ill, his wife should sign the release of information request? Or is it D, you may fax the information without consent um, for the patient since it is an urgent medical condition? And I will say, when I worked in the hospital, this was one of my biggest pet peeves. Wonderful. So we are between the patient will need to give a written release, or we may give the information regardless of that. So, what does HIPAA do and what does it not do? Which I will say for the boards, it should be pretty straightforward. This isn't going to be involving a lot of minutia and teasing out legal language. But when thinking about HIPAA and the privacy rule, basically, you for the use and disclosure of patients' protected health information, you do not need consent first of all, to review the patient's case and records with consultants as long as you're reviewing with consultants for coordination of their care. Which I know goes without kind of saying, why would we talk with the consultants in the first place? And also, consent is not needed to fax or send through secure methods outside medical records as long as it is for the medical care of that patient. Which again probably goes without saying, like, why else would we be requesting information? Now, behavioral health, psychiatry records are kind of our own special caveat that can kind of have some nuances to it, but I would not expect questions about that. And you are allowed to use your judgment in regards to sharing information with family members when a patient is unable to give consent because of if they're altered or otherwise injured or incapacitated. I've included here the link to the full legal writing of the what HIPAA, the full text of it, for those who are curious, as well as the FAQ to help clinicians in this. But really, what it nails down to is if you are taking care of your patient and you need those records, you can share them or request them. And you do not have to have that written consent. And this just details that. So in this case, and again, this is why it was one of my pet peeves. I can't tell you how many times I'd have an outside medical records department tell me, you have to send us a faxed written release of information. You actually don't. You are taking care of that patient for their medical care. They are unable to give the consent. You can then request it, their medical records, and they have to send it to you. Now, that said, a tired medical records person who you're waking up in the middle of the night and who may be a little bit cranky may take some gentle cajoling and some very talking to them in a very friendly and polite manner can probably help your success rate at getting the records back that you're supposed to legally be entitled to. Uh, but you are in firm ground in this regard. So again, I'm glad that we had this case and that I appreciate everyone answering because I think often we feel like, oh no, we need to get a release for anything, but no, you do not. Um, so next question, which again, we're going to continue this theme. So case 9, your hospital team is caring for a patient with Staph aureus sepsis and new neurologic findings, and they have a rash. The skin findings include Osler's nodes, right? We all learned about that in medical school, and Janeway lesions. Your senior resident takes out their cell phone to take foot photos for the patient case review and morning report because, again, how often do you actually get to see Janeway lesions and Osler nodes? So, which of the following applies to be in compliance with the HIPAA security rule in regards to this photo? So the patient should be verbally asked if they consent to the photo via cell phone for teaching purposes. Is it use of the cell phone for photos requires the patient informed consent, noting specifically the use of a personal phone and the security measures you are using to keep that photo secure and safe. Is it HIPAA does not apply since the images do not include identifiable patient information. So you're just taking a picture of the foot. Or a personal cell phone can never be used when requesting photographs of patient findings. All right, thank you, Sharon. Okay, we have literally every answer choice selected here, so hopefully this will be helpful information to you. Although the majority or the plurality picked answer choice B. So what the security rule in mobile devices allows and what it doesn't allow. So the security rule pertains to the protections of the privacy rule, and it applies to health plans, healthcare clearinghouses, and any healthcare provider who is transmitting health information electronically in any form. And of course, there are penalties if this is violated. One of the key things is that if you're going to be sending information electronically, it requires appropriate administrative, physical, and technical safeguards to ensure the confidentiality, the integrity, and security of that protected health information. Um, and you can only transmit information if it is necessary for the care of the patient. Now, one of the pieces that the reason why answer choice D is wrong is the image is protected health information, even if it is not readily recognizable. So even though there's no patient identifying, right, there's no presumably patient badge, there's no medical record number in the picture, it is still considered protected health information. So that's key. Um, and since the data is actually stored on the mobile device itself, you have to be worried about, well, what happens if it's lost? What happens if others have access to it? So cell phone images of patients are problematic. So even if the patient is not identifiable, they're problematic. You need patient-informed consent. You need permission to take the photo, and you need to specify to the patient what it will be used for, and that you're using a personal device, and that indeed there is some security and encryption measures on the phone. If you're using it for educational purposes, you should also get written consent again, because this is for education. In this case, it is not for the care of the patient. It's not that you're taking this photo to go find the dermatologist to get their diagnosis. So not only do you have to get the patient consent, you should get written consent because it's for education, and you do have to specify that it is with a personal phone and that there are appropriate safeguards on the phone to protect that protected health information, i.e. the photo. So the best answer choice here is if you use the cell phone, you require informed consent, and you have to specify you're using a personal phone and that there are appropriate security measures. Hopefully, if you are going to be doing this, you will be using whatever electronic medical record software, hopefully that the institution or the clinic that you are at has. For example, Epic has a feature where it encrypts and keeps that information, uploads it to the chart in a secure fashion that would meet the security measures that are necessary. Um, and I believe other EMRs also can do that. So it is worth you making sure you have that knowledge if you're going to be doing this. I will say in my own practice, as I do home visits, this comes up not infrequently, where I do have to take pictures of rashes in order to take the photo back to a specialist because my patient is homebound and literally cannot get to the specialist. All right, we're going to keep going. Again, we're in the home stretch. We have a 33-year-old patient who's presenting to the ER with urethritis, and they have penile discharge. It shows an intracellular gram-negative diplococci. Right, this is taking us back to medical school. When told of the diagnosis of gonococcal urethritis, the patient says, "Please don't let my wife know. I promise this will never happen again." What should you do? Sharon, if we could launch the next poll, thank you. Should we treat the patient and respect their wish for confidentiality? Should we treat the patient and then instruct him to contact his wife? Should we tell the patient that he and his wife must be treated and then she will be notified about the exposure? Or should we treat the patient and contact the patient's wife to inform her of her risk and need for treatment? Okay. And we have a scattering of different answer choices. It looks like we're between B, C, and D, with the plurality picking C, letting the patient know that he and his wife must be treated and that she'll be notified about the exposure. I will say this has come up a number of times in my career, and these are a little bit, these are always awkward. And so it is helpful to have thought about it and that you have your spiel ready to go. Because if you can say this is what we always do every time, it makes it so much easier in the moment. You just say, matter of factly, this is what needs to happen. So, in terms of confidentiality, the doctor-patient relationship, as hopefully we all know, and based on the answer choices we do, it's not absolute. A patient who asks that medical information be withheld should be honored unless it is in the common good to notify others at risk. This is where like reportable diseases and illnesses come into play, or there would be harm to a specific individual. So, for example, if a patient specifically conveys to their clinician that they have plans to harm someone else, we are obligated to break that confidentiality and inform the authorities. Um, Now, when we think about reportable diseases, um, there are continuously updated guidelines and updated lists of what are reportable illnesses. But there are criteria for state health departments in terms of what needs to be done. And each state has individual rules about not only potentially what is reportable, but also what the process is for reporting. So, in the case of Washington, where probably most of you are right now, and where many of you will be practicing, uh, Washington has said that the primary care clinician is responsible for the notification of partners and the notification of the state. And so, depending on the medical group you are part of, there may not be a process to do that if you're in your own group or if you're starting your own practice, and it behooves you to learn this so that you are doing it appropriately. Now, a small list of some of the reportable illnesses, and this is not exhaustive, but when it comes to sexually transmitted infections, chancroids, chlamydia, gonorrhea, herpes, non-gonococcal urethritis, pelvic inflammatory disease, syphilis, also HIV. Again, that is not an exhaustive list. And it is not only STIs. There's a large list of reportable illnesses. Um, so it is very helpful to know that if you're working with a large medical group that has a clinical lab, or you're working with a large clinical lab, likely they have a process down and a list, and you can work with them when it comes up, and likely they will notify you that this is when something comes up that it is a reportable illness. And there are different rules. HIV often has different rules in different states. Um, and in fact, in Washington, right, the state will reach out to notify, and it's on the obligation of the primary care clinician and the lab to both notify the state about that. So it is very, very helpful to know the process in whatever state you are in. In the case of Washington, and generally speaking across the board, the appropriate answer, the best answer here is to tell the patient that he and his wife must be treated and that she will be notified about the exposure. And it is not sufficient to rely on the patient to contact the spouse. And as far as why it is C and not D, um, you are not obligated to necessarily be the person to contact the wife or the other partners and treat them. You do have to make sure that they will be, that a process will be followed to treat them. So depending on the STI, it may be the state health department or the county health department will reach out to them, and your obligation is to notify that entity, which is why C is the better answer choice here than D. All right. Um, and I'm just going to tackle one of the questions from AP. That's an interesting point. So AP says C seems to imply that the treatment is compulsory. Um, that's a really good question. It is not, and I think here I could have written that question a little bit differently. The treatment is obviously recommended and should be ensured that other partner has access to it and is provided with the treatment. Um, and different conditions potentially are compulsory that they have to have monitored treatment for. In this case, I do not believe gonococcal urethritis is one of those. So I think you're picking out a good point, AP, and I could have phrased it better. And I think probably in the boards, in fact, confidently, it would be phrased better so that it wouldn't imply that it would be compulsory. So really great point there. Ooh, and then Macy. So really good question. So what if the patient promises you they'll tell the partner? Well, so for a reportable illness, there is still a process, usually involving notification again of the state or the appropriate public health entity. So you have an obligation to notify that health entity or that's the health department to do that, regardless of what the patient says. Are you obligated to call that partner and confirm? No, you're not obligated to do that. So hopefully that answers your question. But you are obligated to report it. Yes. Okay. We're going to get to another really thorny case, one that might be really uncomfortable for us as clinicians. So, case 11, you are the primary care physician for a 44-year-old gentleman who has unfortunately polyposis of the colon, so FAP, and recently had a colectomy to reduce the risk of colon cancer. He has two children, ages 18 and 22, from a previous marriage, and family history of a father who died at an early age from a vehicle accident. So we don't have any other history to kind of clarify for sure where the polyposis of the colon, where the gene came from, as the mother is alive and well, but presumably the father. When you discuss the genetics of this condition, the patient says that he does not want to notify his children. So it's a very strange, or not strange, it's a very strained relationship. So, a patient with polyposis of the colon, what should be your response? Sharon, if we could open the poll. So, should we urge the patient to allow you to contact the children? Should you contact the patient's wife? Should you tell the patient that you are legally required to notify the children due to a high risk of cancer? Or should you do nothing since the transmission is autosomal recessive and the risk would therefore be lower? And I apologize for all of you who are saying, well, this was not supposed to be a cancer talk. We have more of those later. All right, so we are between A and C. And I will say, I sympathize with those of you who picked urging the patient to allow you to contact the children, and also really sympathize and empathize with those who are saying telling the patient that you're legally required. Um, Genetics and genetic testing is a complicated area, and the correct answer to this may very well change within 5 to 10 years and may change depending on the state that you are in. So, genetic conditions are different in regards to confidentiality. So, even at present, there are no laws requiring notification of those at risk for an inherited disease, right? Very different than the reportable illnesses on the last question. So, familial polyposis is an example of this. Again, our role as physicians and clinicians, right, we want to do the best for our patients, that beneficence, without doing harm. So we can try to urge the patient to do what we think is best for the health of their children, uh, but there are no laws requiring the notification. And so we are then otherwise bound by the patient's stated desire to, right, protect their confidentiality. And this is still an area where there isn't clear legal justification behind that. So you're kind of in uncertain ground where you're not obligated to say. And so the safer approach here is to urge them to do what you think is probably the most appropriate thing to protect the health of their children. But again, you are not, there's no legal requirement, there's no process to inform them. And so kind of the best you can do is hope that they will then say, okay, let's do so. Now, for those who have been involved in the counseling for genetic testing, you're probably thinking, well, that's part of the discussion before you even do the test, is what happens if we have a result of an autosomal dominant or a condition that's a high risk of transmission and penetrance? What do you do? This comes up all the time in Huntington's. It comes up with some of these, like with BRCAs. So part of the role of genetic counselors that they're really good at is having this discussion before they even do the test so that you're not put in this very situation and that the patient themselves is not put in this situation. But anyways, the correct answer here is urge them to, but you can't make them. And if they say no, you have to abide by that. Now, that said, this is very unlikely to be tested on the boards. This is more for how to think about a challenging ethics situation, recognizing you're balancing different factors, and also hopefully to be helpful to you in your own careers. And as we hopefully all know, FAP is autosomal dominant. It would be nice if it was recessive, but it is not. Okay, case number 12. Your surgical colleague just performed a cholecystectomy on one of your patients. As you're visiting the patient post-op, you talk with the surgeon and you're like, huh, you may be going through alcohol withdrawal. And also you've been wondering for a while about maybe they have Wernicke's encephalopathy. So basically, you are concerned about one of your colleagues being altered and having health issues that would compromise their care. What should you do? Should you kind of ignore it? Charlie will be Charlie after all, and Charlie's a powerful surgeon. Should you talk with Charlie's wife? That is the surgeon's wife. Should you bring it up with the hospital board urgently, or should you talk directly with Charlie and urge them to seek counseling? All right, so we are between hospital board urgently or really recommend that your colleague seek counseling. So here I think the best answer choice is we are obligated to again act in our patient's best interest and really do no harm. So we need to notify the hospital board to protect our patient and other patients from what may be very severe risk to patients from a surgeon who was compromised or any clinician who was compromised. Now, that doesn't mean you can't also encourage your colleague to pursue treatment or get tested and get taken care of. And you may do that as someone who knows them, and hopefully they will rely on you and listen to you and then proceed with doing that. But that is not sufficient, which is why C is a better answer choice than D. And this is fair game for the boards. Right? The appropriate thing to do if we have concerns is to escalate it and make sure that someone who is in a position to then look into it and protect patients is able to do so and does so. So it is our obligation to bring it up with the hospital board urgently or whatever appropriate overseeing institution is. Now, that's very uncomfortable, right? That can be something that could affect your colleague. It can change the dynamics of the hospital. But nonetheless, our first obligation is to our patients. And again, I appreciate those who are thinking D in addition, but really our obligation is to act on a patient's best interest and notify the board urgently. Okay, so in conclusion, when in doubt, do not withhold care in an urgent situation. So the emphasis here is when in doubt. So if a patient hasn't specified and if they're altered and not able to give consent and it's an emergent situation, you are on firm ground to treat. Also, helpful nugget, withholding care and withdrawing care are legally the same. Again, it can feel differently to us, but they are the same. Other points which can be helpful, although generally is not going to be the right answer on the boards, is consider an ethics consult because this requires time. For anyone who's ever been a consultant who helps with ethical cases in their institution, been on the ethics board, or someone who has ever consulted the ethics team, it takes a while. These are not urgent. But they can help really clarify issues, really say, how are we balancing autonomy versus beneficence, and can really spend more time trying to tease it out with a complex family situation. In my experience, that's usually when we've reached to them. Again, really, really challenging family situation with multiple decision makers who are in conflict. Um, it can be helpful to know if your hospital has risk management. They can be a really helpful resource. And generally speaking, and particularly for the boards, court decisions are a last resort. The court takes a long time. Um, and just on a kind of a note for your own personal career, generally cases get handled outside of court. And courts generally don't want to be involved in the day-to-day managing of medical care. And again, courts are slow. Okay, really appreciate everybody participating. Thank you for answering the poll questions. I think there was really helpful to allow us to think about some challenging situations. I've included my email here. It's also on the slides from yesterday. I like this cartoon. I'm the doctor who brings the cards. I am a cardiologist. Okay. And I feel like that is probably a good comic because we're going to have a ton of cardiology cases for the rest of the day.